inflammatory markers. As the name implies, markers of inflammation, the body's stereotyped response to cellular injury. They're also called acute phase reactants, but you can forget that term because it's pointless. Now, inflammatory markers are useful to us for three main reasons. Number one, they allow us to assess the severity of a condition. Number two, they allow us to assess a response to treatments. And number three, they allow us to talk to families in nice simple language about inflammatory markers going up or going down, and therefore allowing us to explain our reasoning for our treatment decisions. The main inflammatory marker I'm going to talk about is CRP, C-reactive protein. C-reactive protein is so named because it binds to the C polysaccharide of Streptococcus pneumonia, which is of course the most common cause of your community-acquired pneumonias. Now, C-reactive protein has a half-life of 19 hours, which means it's not a completely stupid idea to measure it every day, but you probably shouldn't, because what's the point? In most cases, after one day your antibiotics haven't been given a chance to work. For example, beta-lactams take 48 to 36 hours to have any effect. So unless you're using like an aminoglycoside, which takes about 6 hours to work, there's probably no point measuring C-reactive protein more than at the very most alternate days. CRP binds to dead cells. Doesn't matter whether it's your cells or whether it's bacteria. CRP binds to these dead cells and marks them for destruction by phagocytes, a process called opsonization. Therefore, it's a marker of any kind of inflammation, any kind of dying cells in your body, whether that's your own cells as in malignancy or autoimmune conditions, or whether it's bacteria as in infections. Therefore, it's a good marker of inflammation in general, but it doesn't tell you what the cause of the inflammation is at all. But that doesn't matter, it's still useful to us. For example, NICE recommend we use CRP to monitor the progression of a pneumonia. Now you might think, why bother with inflammatory markers at all? We can tell whether a patient's getting better by just asking them, are their symptoms getting better? As they always say, treat the patient, not the numbers. But actually, in many cases, we don't know by asking the patient because they might have cognitive impairment, as in the case of dementia or delirium or both, or the condition that we're trying to monitor the severity of might not be as straightforward as, oh, it got better today. For example, with pneumonia, you can have symptoms for weeks after its resolution. So inflammatory markers are useful to us. When people talk about inflammatory markers, the other thing they're usually checking is the full blood count. And the two main things you want to look at, apart from the white cell count itself, are the neutrophils and the lymphocytes. Neutrophils go up generally in bacterial infections, and lymphocytes will go up in pretty much any other kind of infection, whether that be fungi or TB. The other thing is lymphocytes will often go down in the case of influenza and other respiratory viral infections, so that's another sign to look out for. But FBCs and CRP together are what constitute your general inflammatory markers. The reason we like to measure more than one inflammatory marker is that you can have certain things affecting them. For example, CRP often lags behind the full blood count, and the full blood count can be affected by a variety of conditions. For example, if you're on steroids, that will cause the margination of your neutrophils and cause them to artificially increase, even if there's no infection present. So we need the full picture. But that's not the end of the topic, because there are other blood tests which can act as markers of inflammation, even when you don't want them to. The one I'm going to talk about is ferritin, because that's the most common one. Often when a patient's in hospital, we'll look at the full blood count and we'll find that they're anemic, and we'll want to know, why are they anemic? So we'll do the hematinics, which is your standard battery of tests for your deficiencies that often cause anemia. So it's B12, folate, iron status, transferrin saturation, and ferritin. Ferritin binds to iron and transports it, that's its whole point. But it's also classed as a positive acute phase reactant. In other words, an inflammatory marker that goes up when there's inflammation. Why is this? Well, the key thing to know is that bacteria absolutely love iron. They find it absolutely delish. I just love it, me. Of course, the real question is why all bacteria are suddenly from Yorkshire, but that's for another day. So, when we have an infection and we're full of bacteria, our body will do everything it can to squirrel away the iron into its storage places so that it's not just sat there for the bacteria to feast on like locusts. That means your ferritin will increase and your iron status will decrease. It will look like you've got iron deficiency. Because of this, you'll often see people going, this patient has an iron deficiency, I'm going to treat them with intravenous iron. Stop! Do not do this. The only reason they've got an iron deficiency is because they've got an infection. Only treat an iron deficiency after the infection's resolved and you've rechecked to make sure it's a true iron deficiency. Very, very, very rarely you might find that ferritin is massively raised. We're talking over 10,000. There's only one thing that really causes this, and that's hemophagocytic lymphohistiocytosis, or HLH for short. It's exactly what it says on the tin. It's an exaggerated immune response, loads of lymphocytes eating away at your red blood cells and pretty much everything else. And it can attack pretty much any organ in the body and cause, for example, acute respiratory distress syndrome. There's absolutely no reason why I'm talking about this. HLH is usually familial, that is, there's a genetic reason behind it, but it can also be acquired, so usually in the case of cancer, autoimmune conditions or certain viral infections. Of course, this is very, very rare, but it happens. The other thing we like to measure in HLH is another inflammatory marker called lactate dehydrogenase, or LDH. LDH is found in most cells, so when those cells die, they release LDH and we can measure it. And it's usually used as markers of two things: hemolysis and tissue turnover in the case of malignancies. When you've got loads of proliferating cells and therefore lots of dying cells, you can use LDH as a marker of how fast that's happening. Inflammation is a procoagulable state. In other words, your body thinks it's injured, so it's going to try and clot. That means that all your markers of clotting will now be acting as markers of inflammation too. For example, D-dimer will increase. D-dimer is a product of the breakdown of clots. So, if you're suspecting a venous thromboembolism, don't bother doing a D-dimer if your CRP isn't normal, because your D-dimer will just be increased anyway. For example, if you're suspecting a PE in a post-operative patient, go straight to a CTPA because the D-dimer isn't going to tell you anything, it's going to be raised anyway. Because D-dimer is an inflammatory marker, it's got a very low specificity, but it's got a high negative predictive value, so if it's negative you can be pretty sure that there's no clots happening. The last inflammatory marker I'm going to talk about is albumin. Albumin is normally measured as part of the liver function tests, but like the other things we've spoken about, it can act as an inflammatory marker, different from all the other things I've talked about because it's a negative acute phase reactant. That means it goes down when there's inflammation. The reason for that is albumin is a huge protein. It's 65 to 70 kilodaltons in size. When there's inflammation, our body wants to conserve all the amino acids to make proteins that are actually going to be useful in fighting the source of the inflammation. So albumin gets thrown under the bus. Now, what are the functions of albumin normally? Well, it's mostly just a transport protein. It carries stuff. One thing to be aware of is that albumin is also a measure of liver function because it's made by the liver, so when there's liver failure, the amount of albumin being produced will decrease.